We are so happy you're here to hear Dr. Alizadeh discuss birth injuries for the attorney. I'm Dr. Amy Fogelman, and I'm so honored to be here as the CEO of High Rock Experts. Next slide, please. This has been an exciting journey, and I am glad to see a lot of familiar faces here. I've dedicated over 2 decades to caring for patients within Harvard-affiliated practices in the Boston area. In 2018, I founded High Rock Experts with a core mission to provide ethical and credible expert reviews. We've matched close to 600 medical experts with attorneys across the United States. And in 2020, we created High Rock Academy to teach medical professionals how to become credible experts themselves. I'm pleased to introduce another one of our Academy graduates, Dr. Pouneh Alizadeh, who will share her insights with you shortly. Next slide. So let's move on to our main event, the next slide. I'm pleased to welcome Dr. Alizadeh, and she's a board-certified obstetrician and gynecologist. She completed her residency in Denver, Colorado, where she delivered over 600 babies. She continued on to join and grow a thriving practice serving as the physician director. Dr. Alizadeh has held leadership roles with the American College of Obstetricians and Gynecologists. She currently works in multiple clinical hospital settings across the U.S. to provide critical health care to women in underserved areas. So take it away.
Well, thank you, Dr. Fogelman, for the kind introduction. And I am so pleased to be here with you today to give you my perspective as an obstetrician on birth injuries. I did all my training in Colorado, so if there are any Colorado State Rams out there, go Rammies. I'm an osteopathic physician, and I am board certified, and currently work in multiple clinical settings in rural and community hospitals, which has allowed me to gain a different perspective on how standard of care is delivered amongst different resource availability and personnel availability. I thought I'd share some photos of me in action. This one was my very first delivery as a medical student about over a decade ago. And my glasses were slipping off. And so my attending thought it would be humorous to tape it across my face. So I'm not sure what the patient thought of that, but it always brings me good memories. This is me teaching some medical students how to deliver babies vaginally. And this is me doing a C-section in practice. It's probably not a surprise to any of you out there that obstetrical claims are high. About 50% of OBGYNs will get sued before they turn 55. And many OBGYNs will be sued more than one time. Primarily, OBGYNs and obstetrical claims stem from having a neurologically impaired infant or patients who unfortunately suffer a stillborn or neonatal death. And there's 3 main reasons where these occur. The first is a delay in treatment of fetal distress. And we'll discuss this in a couple of slides about how to determine fetal distress or the things that we can do. And the second one is improper performance of delivery. So babies are delivered vaginally or via C-section. You also can have a vaginal assisted delivery with forceps or vacuums. And any improper performance of those procedures can impact a fetus or a neonate. And then the last one's improper management of pregnancy. We won't discuss that today. There are lots of guidelines in order to determine how to manage a pregnancy. And when you have a medical expert, obstetrician, they'll help you determine whether the right steps were taken or not. The reason this malpractice obstetrical claims are so prevalent because nobody really wants anything bad to happen. You know, women and couples get pregnant, and this is typically a happy part of their life. And for most of the time, things go well. But when they don't, they can really take a turn south. And having a neurologically impaired infant has a huge impact on not only that family, community, that baby. You know, these are some of the reasons why you as attorneys might see these suits more frequently. To get into just the basic definition of a birth injury, so it's an impairment of a neonate's body function or structure due to an adverse event occurred at birth. So basically, something happens at the time of labor and delivery that's going to affect the child's function, either neurologically, metabolically, or physically. Okay. And so these are some type of injuries that can happen. So in kind of simple terms, you can have injuries that are pretty minor, a little bit of swelling of the scalp that have no long-term effects. You can have small little lacerations or cuts on the baby that you do a little skin glue and the babies heal fine, and it's their first of many childhood injuries. But there's also other injuries that are more impactful. So during the labor and delivery process, if there's any lack of oxygen delivered to the child, they can have cerebral palsy. If there's any issues with delivering the shoulder of the baby, you can have nerve injury to a shoulder, which will not allow that child to potentially have function of their arm, although some of them, it is recoverable for some of the injuries. Other injuries that can happen are breaking bones. So sometimes the clavicle can break even without any assistance. It can occur spontaneously, but most commonly associated when that shoulder gets stuck. Nerve injuries, you kind of get the idea. And the biggest thing, again, nobody gets pregnant and has a baby to have a bad outcome. And, thankfully, as obstetricians, the bad outcomes are few and far between. Although it might seem as attorneys that you're seeing all of the bad outcomes. But for us and an expert is really to determine, is this just a bad outcome, or is there a medical error? And it's easy in terms of determining if there's a medical error when there's an egregious error, right? When there's a medication administration that is wrong, wrong site surgery. These are very clearly medical errors, and there can be a gray zone in that. And so having our expert witness can be really helpful in determining kind of what happened and if anything could have been prevented. Risk factors. So I just wanted to touch upon some things that you might read as you're reviewing medical records that will give you maybe perk your ears up that a woman would be at higher risk of potentially sustaining a birth injury. And so we'll look at risk factors for baby and moms. So a large baby, okay, large babies can get stuck, can increase the risk of birth injury. A big head, again, they can get stuck. Prematurity or low birth weight. When babies are early or they weigh less, they're more fragile. And so some of their blood vessels can be more fragile. And so that can be a risk. Any birth defects that might have been diagnosed via ultrasound earlier in pregnancy can put the baby at higher risk of having an event occur at the time of delivery. And then abnormal position. So for deliveries, especially vaginal deliveries, the head should be down. But when they go butt first, which is what breaches, that puts them at higher risk. And again, a multitude of different presentations that the baby can try to come out. For the moms, there are a few also things in their medical history that could put them at higher risk. If they're obese, they have diabetes. If the mom's small, again, some of the stuff is a fit thing, is the mother has a small stature and the baby is big, that can predispose you to potentially having issues at the time of delivery. First pregnancy, path hasn't been paved. it's more difficult than subsequent pregnancies when you've known a mom has birthed a child in that way. And then the use of assisted devices like vacuum or forceps that I just mentioned earlier, and long labors. Long labors can cue you in that maybe there is a fit issue. It also makes it more probable that there is less oxygen being delivered as that uterus is working hard to deliver the baby. So that's kind of the medical risk factors. I want to briefly touch on something called maternal levels of care. As there is a rising maternal morbidity and mortality in the US, and there is great disparity amongst hospitals and the resources that they provide, they've made a system that basically has hospitals that provide a basic level of maternity care, and then hospitals that have more resources, that have all your specialists that can provide that higher level of care. So when you're taking care of a woman and her baby, you want to make sure she's delivering in one of those places that can take care of her. There's 4 levels of care, and there's a long list of what is included at each of these levels. A level 1 is essentially a very low risk pregnancy. The providers that are attending these deliveries can be a family practice provider. It does not necessarily need to be an obstetrician. The family practice provider should have C-section privileges. Sometimes it's a midwife primarily taking care of the patient with either an obstetrician or a family practice patient with C-section privileges. There's specialty care, which is kind of one step up. Typically an OBGYN is involved in the care. You have access to a specialist called a maternal fetal medicine specialist. And when you're reviewing records, you might see these couple of names. So there can be a midwife involved in the care. There could be a family practice physician who does OB. There can be an obstetrician, and they might consult with a maternal fetal medicine physician who they might consult with a maternal fetal medicine specialist. You might see it as MFM in the medical records, and they are a subspecialist. So they're OBGYN who then went on and did 4 years of subspecialty, only high risk obstetrical care. In level 2s, they have access to them either by phone or telemedicine, but not necessarily in person. 3, you got everything. 4, you got everything and more. Okay, those are kind of the basics. This is a map of maternity care deserts as of 2020. The red is indicative of counties with no obstetricians. And so it's really important to recognize the paucity of maternity care providers across the US. When you have an expert who reviews your records, it's important to understand the kind of dynamics that occur in these smaller counties where it might take 4 hours to transfer a patient. Some of these places are in areas with poor weather and a helicopter can't fly. There can be some barriers based on resources and settings. As obstetricians, our primary goal is to keep mom and baby safe. Obstetricians have to balance their availability of resources with some barriers to care in a delivery room in a rural area. There could just be the midwife and one nurse. Typically, there might be another nurse that will take care of the baby, and that's kind of it in the room. In the smaller hospitals, your obstetrician is not at the hospital 24/7, so they may be at home, can take them 10 minutes to get there, 15 minutes. Usually the callback time is about 20 minutes. And then you want to compare that to a hospital that has all of your resources. You have residents, medical students, fellows, your attendings, and then add that for each specialty. And so in your delivery room, you might have 4 people on your obstetrical team. You might have 3 people on your pediatric team. Obstetrics is very much a team sport. It's all hands on deck. And it's important for everybody to have their eyes on the patients. And so, again, some nuances in how maternity care is delivered. There is a recent popularity on birth plans, and there is a lot of influence of social media on obstetrical care. And so some of the challenges as an obstetrician is kind of debunking what is out there while really fostering that the patient still has autonomy, and you want to make sure that you are explaining everything and that they have choices in their care and they understand their care. But some of the things that are out there are not necessarily safe. There's been more push to have low interventions and have deliveries outside of the hospital. So home births and birth center births are certainly on the rise. And for birth center births, there's some women that it's an okay option for, especially, again, if they have good backup plans, and that's something your expert can help you look at is, okay, this patient may be delivered at a birth center. What was the contingency plan if things didn't go right or wrong? And was there? And there should be. So we're going to get into reviewing some cases. This patient is receiving prenatal care from a physician and midwife collaboration group. Okay, not uncommon to have. Her baby was measuring larger than average. The due date is about 40 weeks of pregnancy, and we let women kind of go 1 week after, typically. Okay, so she went 1 week past her due date. She didn't go into labor. 1 week after your due date, if there's no signs of labor, it's better to have baby out and in to reduce that risk of stillbirth. So her labor was primarily managed by a midwife with physician consultation. She pushed for 2 hours. She rested for an additional hour. And then because she hadn't delivered her baby, a cesarean delivery was recommended. A review of the delivery report. The infant was delivered via forceps. Indication was non-reassuring fetal heart tracing. It's also called fetal bradycardia. Bradycardia meaning low heart rate. So heart rate dropped. The baby had a swollen left eye when it was born, had some blood within it. And the mother had a 4th degree laceration, which is kind of the worst laceration that you can get. And then the baby indeed was large at birth. This is what in a labor and delivery unit, this is posted everywhere at the nurse's station, typically in the physician call rooms and the physician workstations. We are monitoring these strips. And we have different categories. So when you're reviewing medical records, when your expert's reviewing it, you'll see a category 1 strip. And that means normal, reassuring, this baby is happy. Just to orient you to what this is. So up here is the baby's heart rate, and down here is mom's contractions. So the baby's heart rate, we talk about a baseline. So basically that's this line that's going through. And then we want the heart rate to go up. We call that an acceleration. That lets us know baby's healthy, their nervous system is responding appropriately, and that's reassuring to us. In addition to that, we like this zigzagginess. We call that variability. Okay, again, shows us that there's a happy baby. This is a category 2 strip. There's 3 categories, 1, 2, 3. 1 being the best, 3 being the worst, 2 being the majority of fetal monitoring strips in labor. Because it's important to remember that labor is stressful for a baby, and you're going to see strip, changes in the heart rate and in the category 2 strip. The importance and what your expert can help you determine is how long was that baby in a category 2 strip, where there are reassuring periods in between, where things being done. This is the baseline up here, okay? This kind of straight line. And then the heart rate drops, okay? And this is bradycardia, these little hills. And then these little peaks that you can see, this is the mom pushing. This mom is pushing. The baby's heart rate is going down with the pushing, but then it comes back, and the beat to beat change, the variability is good. So for me, this is a kind of expected tracing for someone who's pushing. However, you don't want to sit at this tracing for a long time. These are category 3 strips. So what category 3 means, deliver immediately. Okay, you don't watch a category 3 strip. It shows you that your baby is in trouble. Beat to beat was great, and then the heart rate went down and stayed down. So this is kind of going back to that case where a C-section was recommended, but then all of a sudden the baby didn't look great and they did a delivery via forceps. The heart rate went down and then it stayed down. And the fastest way to get a baby out was forceps rather than moving to an operating room and performing a C-section. This is also a category 3 strip. This is flat. You never want to see a baby flat. Okay. This tells us that the baby's not doing well. Okay. Should be delivered. And again, you can see these are contractions, these little mountains. This is what a forceps looks like. They're metal spoons that go in the vagina and on the baby's face, and the physician pulls while the mom still pushes. Very important when you're doing any assisted delivery. There's a whole checklist. Again, when your expert reviews these medical records, they can ensure that all the things were properly evaluated, including fetal head position. Okay, you want to know exactly which way this baby is facing, because you want to make sure you're putting these forceps where they need to be. Okay, kind of right on the cheek. Back to our case, the baby saw an ophthalmologist, and they did confirm that the cornea of the eye was cut and there was bleeding, and that was secondary to the forceps blades being placed over the eye. And so I'm going to go back to this. As you can imagine, if the forceps are placed here, then and these are metal, you can scratch, you can hurt the baby. Condition was severe, but it was treatable. Plaintiff alleged that failure to perform earlier cesarean delivery and improper performance of the forceps delivery resulted in laceration of the infant's lower eyelid, left cornea. The defendant testified that cesarean delivery was not indicated earlier, and forceps were performed due to fetal distress, and a delay in delivery could have resulted in fetal death. This case settled after 2 days of trial for $200,000. Case 2. All right, so now we have a 19-year-old. It's her first pregnancy. She presented to the hospital in early labor. This hospital, imagine it's a level 3, or one of the higher levels. There's residents, there's midwives. The physician is at the hospital 24/7 doing shift work. Okay. Her pregnancy was uncomplicated, although her labor was, we call, protracted or long. Her fetal heart rate tracing was category 1, which now you know what category 1 is, so it was normal. She had a fever during her labor course and was diagnosed with an infection, was given antibiotics. Then her fetal heart tracing became category 2, which we talked about can occur in labor. A physician evaluated her and indicated that a cesarean delivery would be indicated if there was a persistent category 2 fetal heart tracing, or if her cervix hadn't changed, or she wasn't closer to delivery in 2 hours. 2 hours later, the resident and the midwife on the team examined the patient. There was no progress in labor. They recommended waiting an additional 2 hours, and at that point there was progress in labor. Shift change occurred and a new midwife assumed care. The fetal heart tracing had multiple dips in the heart rate, so it was persistently category 2. The same resident that evaluated her with the midwife kind of earlier in the night came back with now a new attending physician, and they recommended a C-section at that point. The baby was born and did well. And despite, the fetal heart abnormalities, the baby had normal APGARs and umbilical cord gases. And I recognize this is maybe not a term that you are familiar with, but essentially this is how we evaluate that a baby was well oxygenated and doesn't have any significant risk factors for reduced oxygen and like cerebral palsy, etc. So the APGAR is based on looking at the baby, their tone, their breathing, their color, okay? And then the umbilical cord gases are actually drawing blood off of the umbilical cord to get a value to see if there is any decreased oxygen. In simple terms, your experts will help you determine that. So the baby was delivered via cesarean, and then the placenta was delivered after the baby, and they had persistent bleeding. They gave medications that they routinely give when there's bleeding. They called an emergency alert overhead. As you could imagine, there's a loudspeaker in the hospital. They call an alert, and then that activates additional personnel and resources to come to the room. They perform surgical maneuver, which were not helpful. And so they made a decision to remove the uterus or do a hysterectomy to control the blood loss. They had a second opinion on this, provided by the department chair, who's typically a physician. And then their total blood loss was about 3 liters. Okay. Afterwards, the patient was grateful for her life and her baby's life, and felt like the proper decisions were being made. 2 years later, the patient filed a suit against the physicians in the hospital for unnecessary hysterectomy following her cesarean delivery. And you can imagine this is a 19-year-old, so that decision is not taken lightly. The case proceeded to trial. The plaintiff expert opined that cesarean delivery should have been performed earlier due to her abnormal progress in labor and the fetal heart changes, and that delay is what resulted in her need for hysterectomy. The defense essentially testified that the record reflected ongoing, timely, and appropriate evaluation, and the jury returned a defense verdict. So clear as mud. As you know, obstetricians have 2 patients here, and sometimes one decision is more harmful to the other. So for example, in this last case, cesarean delivery was done for fetal indications and the baby was born normally. However, the mother sustained complications from cesarean, and now as a 19-year-old, she has her one and only child. And so there's a big balance in when these interventions are done and how they're done. And as I mentioned earlier, some of the complicating factors is a lot of the patients don't want intervention either, but it's important that when you're reviewing these records, if that's expressed, is it documented as well? These are my references, and now I am ready for all your questions.
Thank you. That is really excellent and gives me a lot of empathy for, gosh, what you have to balance when you're taking care of your patients. There's a long question from one of the attorneys, and I will allow him to ask, but just wondering if birth injuries can be avoided by early cesarean section, why isn't doing cesarean section the norm?
Yeah, like why aren't we like Brazil that has a 50% cesarean section rate? It's a great question. One of the reasons is in this pregnancy, if you're doing a cesarean, and if it was planned, so woman was not in labor, you just plan a cesarean, that is the safest, okay? Safest for mom, safest for baby. The issue comes in subsequent pregnancies. And so maybe some of the attorneys have had cases about VBACs or vaginal births after cesarean, TOLACs, trial of labor after cesarean. What occurs is when you have that scar on the uterus and then another baby grows in and the pregnancy distends it, that scar can open up. And so you can have a uterine rupture, which the literature quotes about 25% rate of neonatal morbidities and brain damage to the baby. So it's a really high risk. And so if it occurs, the ruptures occur about 1% of the time. So again, 99% of the time, totally fine. 1% chance of having, a quarter chance of having a neurologically impaired child is a huge risk. So there's that. In addition to that, the placentas can adhere abnormally to that scar and lead to hysterectomy at the time of delivery. And The other thing is scar tissue formation. So we can't predict which women will develop scar tissue or not, but if you've had multiple C-sections, you can have bladder being stuck to the uterus or bowel, and then you're at increased risk of bowel or bladder injuries. So that's also not great for mom. And that I touched on earlier, women don't necessarily always want C-sections. There's a huge social media current culture to have a low intervention, and a C-section, even if indicated, is sometimes declined by a patient. And interestingly, because of all of those issues related to C-section, our quality organizations are actually trying to prevent primary cesarean deliveries. And so we actually have a whole checklist that we have to complete in order to perform a cesarean delivery. In some units, like the rate of primary C-section is posted by physician or by practice in the unit. So there is a culture to really decrease the number of C-sections. Even though if you could prevent a birth injury, just, why not do it? So it's an interesting balance.
Got it. Okay, there is a extensive question from one of the attorneys.
Okay.
Carrie Choi, I'm going to try to unmute you. Hopefully you're still around, and then you can ask the question directly to Dr. Alizadeh if you're there.
Yes, I'm here. I don't know if you can hear me, however.
We can. Perfect.
Good afternoon, doctor. I apologize for the length of the question. I just wanted to make sure that you had enough specific detail to answer. I'm looking at a matter involving preterm labor at 6 months gestational age. Patient was brought in to the hospital. She's monitored for 6 days with fetal tracings. The baby was delivered spontaneously, emerging limp and apneic with no heart rate or response to tactile stimulation. O2 sats were undetectable. The baby was intubated, but after about 12, 15 minutes, they were not successful in resuscitating the baby, and the baby was pronounced dead. Autopsy stated lack of autolytic changes with evidence of acute injury consistent with intrapartum death. Soft tissue edema of the head, neck, and larynx likely represent the effect of external constriction, limiting venous flow from the head. Subcutaneous scalp swelling, scalp hemorrhage, and disruption of the liver also suggest extrinsic entrapment during delivery. And I have two questions. One, is this extrinsic entrapment a recognized cause of death? And the second question is that I've tried several times to have the hospital send me the tracings, and I'm told that the tracings don't exist. All I have is kind of a template summary.
Mr. Choi, that is an interesting case. There are periods where extrinsic entrapment can occur. Have I seen an autopsy like that? And no, typically is there rarer cases. What's coming to mind is, was there a head entrapment? Was this a breech delivery and the head got stuck and they couldn't get it out? There's something called a Bandel's ring in a C-section where there's a kind of like a thickened muscle that almost is like a tourniquet on the baby's head when you bring it out. And so, did something like that happen?
No, I'm told and understand there was no alarm. It's as though, there's supposed to be this close monitoring with fetal tracings, and it's as though, there was no call for a C-section. Just the baby arrived and couldn't be resuscitated, which strikes me as somewhat odd.
Yeah, I would dive in. I would have somebody look at those a little bit more closely. That's not a typical autopsy result as from a preterm delivery or like a stillborn or neonatal death. That's not a it's typically not worded like that in terms of extrinsic.
And the second question relates to new technology, and that is, I'm used to over the years seeing the normal fetal tracing such as you displayed. Is there new technology now where that is not made part of the record, and that, somehow there's a computer program that stores it as a kind of a narrative summary? Or
Yes. Yes. Previously, it used to be on paper, printed off, scanned into the charts. And now there's a multitude of different fetal monitoring programs. Every institution uses a different one. It allows for kind of remote monitoring. It allows for the nurses not to have to be at bedside, but to be also watching it when they're out at the desks. In addition to physicians and providers who are not in the hospital, they're able to log on to it. But you are correct that a lot of the nurses will annotate in this software, but they should be able to share that with you as part of the record. And that's, to me, is actually one of the most helpful parts of the medical record, is because you will see the nurse's notes associated with the fetal heart tracing. So you know exactly when they called the physician, exactly when patients started pushing, etc. It's a time stamped and really one of the most valuable components of a record.
But the nurses, the clinicians are actually looking at what would be the normal traditional tracing with the contractions at the bottom and the fetal heart rate on the top line. Is that correct?
Correct. It's the same thing. It's just on a computer program, a separate computer program.
Thank you.
Yeah, absolutely.
All right, so Carrie, I'm going to mute you again. And then Delisha McCrae, let me find you. Okay, Delisha McCrae.
I just had a question about the case that the lawyer just talked about. I'm a perinatal pathologist.
Okay.
I've seen similar findings with that. If you have abnormally long or short umbilical cord, I didn't know if the cord was looked at on this case, ischemic changes within the cord, like if the baby got intermittently wrapped up in the cord sometimes, because it can cause similar issues if it wraps around the neck a couple of times and is not seen on ultrasound, versus it can wrap it tight and then unwrap depending if the cord is too long or too short. So that can sometimes in autopsy have similar findings.
So that's another thing, Dr. Choi, to look into, and especially with an unusual autopsy like that, you very well might be helpful to have a pathologist like Dr. McCrae to look at the records as well.
And make sure it's a perinatal pathologist, because the average pathologist might not notice something different within the cord.
All right. Any other questions that we have? Any new cases? I have another question. What do you look for when you're reviewing medical records for birth injury?
Yeah, so I look at some of, initially the risk factors I had talked about earlier in the presentation, to see if there's any predisposing risk factors for it. And as I was talking to Dr. Choi, I really look at that fetal heart rate tracing with the nursing annotation to see the timeline. So in obstetrics, timeline is so important. Minutes matter, and trying to piece together what happened in maybe a short period of time. The tracing is really, really important. And if there was any, change in plan or maybe action not taken, looking at the documentation and is there a reason? Sometimes things change in the labor course and look better or look worse. It's important that that is described and that there is an explanation for the next step in management.
There's another comment from another expert that we have here. So her name is Heidi Brown. So let me allow Nurse Brown to speak.
Good afternoon. So I just wanted to comment again on the previous case that was offered up of please make sure you can always get the tracings. And if they are, if there's an order for monitoring and they are monitored, you can always get those. And a lot of it depends on where the patient was. If the patient was on an antepartum mutant as opposed to labor and delivery, sort of the qualifications of the nurse are a little bit different. And should this patient have been moved from an antepartum mutant to a labor and delivery before this delivery occurred, and make sure that you are asking for audit trails. They are super helpful in letting you know was the documentation that occurred happening in real time, or was it delayed? Was it even at the patient bedside? So really important information.
Thank you very much.
I think this is just a great testament to how important it is. I don't think maybe Dr. Fogelman was going to say this, but how important it is to have different experts opining on a case, because we all take care of this patient in kind of different venues, but together as a team. And so it's great to hear the nuances and the considerations of each team member.
Definitely. Thank you very much, Nurse Brown. We appreciate your thoughts.
I don't, can people hear me?
Yes.
Oh, great. I just wanted to thank the participants for the comments and to respond directly to the question about the umbilical cord. There's no mention in the autopsy report of any cord abnormality. And what's interesting also, if there's lawyers out there, I probably now, because I've asked multiple times for the tracings and have been told that there aren't any, I just have this type of template summary. I'm probably going to have to start suit as a discovery suit against the hospital.
In the delivery note, was there any mention of a nuchal cord?
No.
No. Okay.
No, that would be an explanation that I'm familiar with.
Sure. Okay.
All right.
This is just, this is a tertiary hospital, and it is a problem in Massachusetts law that because of charitable immunity, unlike, for example, New Hampshire, where you can just sue the hospital and figure out which providers, on staff may have been at fault. In Massachusetts, it's essential to name individuals.
Yeah. Thank you. We appreciate you, Attorney Choi, and your thoughtfulness. We're going to answer this one live.
Hello.
Hi, go ahead.
So I'm trying to find out whether the doctors, whenever they're in the litigation process, because it hasn't been able to be resolved pre-suit, whether they really understand how the negotiations are going in between the plaintiff's attorneys and the defense attorneys, or if that's basically kind of kept in the dark from them.
You mean as expert witnesses?
I'm normally as a defendant. So if the OB is being sued, then are they going to be informed of how this negotiation process works? Or are they going to even know how that is going to happen?
Sure.
I can give just a little bit of perspective from the plaintiff side, from what I generally understand. And my practice is exclusively plaintiff, although our firm does regularly represent as personal counsel doctors who are being sued. And my comment is generally the insured physician is kept abreast by their insurance assigned counsel. There's a fairly moderately sized, maybe small size, a very capable medical malpractice defense bar, and they're very good at what they do. However, the problem arises where sometimes there is a divergence of interests, what's best for the insurance company and what's best for the doctor. And for that reason, it is frequently important for a physician being sued, particularly in a situation where the damages are significant and the coverage may be limited, to retain their own counsel, because the attorneys who represent the doctors hired by the insurance company are very reluctant, understandably, to threaten the insurance companies that they better settle this, even though it may cost a fair amount of money, because the doctor's assets may be exposed. So that's something that I don't think is as well appreciated by the individual physicians as should be.
And from a physician perspective, in terms of medical education and training, we don't typically get education on malpractice suits throughout medical school or even in residency. And being an obstetrician, where more than half of us are likely to get sued, and even in that case, we don't learn about it till we experience it. And so sometimes it's the first time for these physicians to be involved in these types of negotiations and kind of the legal process.
Thank you very much. And then we have Dr. McCrae wants to say something to Dr. Choi. So we're going to let Dr. McCrae come back in and talk to Dr. Choi. So Dr. McCrae, go ahead.
Can you hear me?
Yes.
So one thing I was going to say to Dr. Choi, if you
Sorry,
just
Attorney Choi.
One thing that I've seen to some of the cases I've had is they just look for abnormal umbilical cord length. So if the umbilical cord length is less than 10th percentile or greater than 90th percentile, that can be perceived as the cause of this demise.
Yes.
So if it's less than the 10th percentile or greater than the 90th percentile, you can actually Google and come up with charts. There's charts online, usually like published articles of umbilical cord length. And if it's below the 10th or above the 90th, it can be the perceived cause, because it might not necessarily be wrapped around the neck during delivery, but that means it might have been intermittently wrapped around and unwrapped itself several times. It still can be an umbilical cord issue, even though it wasn't seen on delivery. You're welcome.
This is great. All right, I think we're ready. Just one last question. Do you think that are women aware and consented for the risk of hysterectomy after delivery?
They should be. In a cesarean delivery, it's a surgery, so there's a written consent. There are some institutions that implement a consent for vaginal delivery as well, but patients should be verbally aware that that can occur.